All right, this is Carl. I'll be discussing sensorineural hearing loss in adults. This is from Cummings, Otolaryngology, chapter 152. This is a very broad topic, lots of items discussed in this chapter. I'll try to move quickly so we can cover all the main points, and I'll try to emphasize items that tend to show up on boards and in service. You may hear some small voices in the background. Those are my kids. Unfortunately, it's raining outside right now, so I apologize in advance for any distraction. So to jump right in, normal hearing depends on the integrity of middle ear mechanics as well as normal cochlear function, specifically its micromechanical, cellular function and biochemical environment, and adequate function of CNS pathways and nuclei. So diseases of almost any physiologic system can affect hearing. And sensorineural hearing loss in adults is very common, and it has a very wide spectrum of severity. Unfortunately, it's frequently overlooked due to its insidious onset and patients' ability to compensate. So when we're doing our clinical evaluation and taking history, it's very important to characterize the degree of loss, laterality, chronicity, and any associated symptoms such as vertigo, tinnitus, notalgia, otorrhea, headaches, oral fullness, etc. Past medical history should be scrutinized for any cardiovascular disease, rheumatologic, endocrine, or neurologic disorders. Renal insufficiency is an important contributor to find out about, and any head trauma. Past surgical history should be explored for any ear surgery, any past neurosurgery. Social history should be discussed with respect to the patient's occupation and hobbies as they pertain to risk for hearing loss, as well as their use of hearing protection. Family history should be discussed with respect to any unusual hearing loss in close relatives or any inherited or common familial intracranial tumors. Physical exam should be thorough and should include an otoscopic exam, a microscopic exam, tuning forks, full cranial nerve evaluation, and vestibular testing when appropriate. Any patient coming in with hearing loss needs an audiogram. The minimum battery includes air conduction, bone conduction, speech discrim, and tympanometry. Additional tests can be helpful. ABRs can be useful for patients who are difficult to test, such as children. Historically, these have been used to look for retrocochlear pathology, although this test is a lot less reliable for smaller CPA lesions. ECOG, very controversial as to how useful this is. It is in the literature, it is in textbooks that you can use an ECOG to look for Meniere's or third window via an elevated SP-AP ratio. As we discussed last week, that's a pretty controversial topic, but important to know that it's out there. Otoacoustic emissions, which essentially is acoustic energy generated by the cochlea, is also potentially useful. Important to know that this looks just at outer hair cell dysfunction, and it really doesn't, OAs don't really show up with hearing loss that's greater than 3 dB, so it does have some limitations. Vestibular testing can be adjunctive in some patients. Lab testing is rarely helpful. There are some rare exceptions for this, for example, looking for patients with syphilis or potentially testing for HIV, as we'll discuss later. Radiographic testing obviously can be warranted in select patients with an MRI and or CT. So getting into disorders that can affect adults, this is a brief topic, a brief discussion about developmental and hereditary disorders. We typically think of these as affecting kids, but adults can suffer from inherited loss. And probably the one area that we still have not really fully elucidated is noise-induced hearing loss. It's likely that there's a non-syndromic hereditary predisposition for noise-induced hearing loss. We don't understand it very well, but a lot of patients will suffer greater loss than their colleagues exposed to the same amount of noise. So it's likely that there's a genetic component that has not been very well elucidated. Syndromic hearing loss can also present in the adult, in an adult time frame. Warrenberg syndrome is something that you may see once in a while with adults presenting with hearing loss later in life. This is an autosomally dominant disease. Findings include dystopia canthorum, a broad nasal root, cynophorus or unibrow, heterochromia iridis, and a white forelock. And hearing loss can be quite variable from none to profound, and vestibular abnormalities may also be encountered. Another syndromic form of loss is Alport syndrome. This was once thought to be autosomal dominant in inheritance. It's now known to be pretty heterogeneous. Patients will present with interstitial nephritis that often leads to renal failure. Sensorineural loss tends to occur in the second decade of life. and patients may or may not have ocular manifestations. Usher syndrome is another syndromic form of loss that can present in the adult period. This is autosomal recessive inheritance. About 1 in 100 patients or individuals are carriers. Patients can have retinitis pigmentosa, sensory neural hearing loss, and may or may not have vestibular deficits. The type to remember for adult onset loss is type 3. This is the least common form of Usher's, and it presents with progressive sensory neural loss beginning in adolescence. Just for completeness sake, type 1 and type 2 both involve congenital hearing loss. Type 1 has absent vestibular function, while type 2 has normal vestibular function, and type 1 has an earlier onset for retinitis. EVA is another phenomena that can be seen with certain syndromes. It can also occur in isolation as part of a Mondini malformation, but you can see it, for example, with BOR, Pendred, or Charge. These patients can have any level of sensory neural loss. It tends to be bilateral, and it often will progress in a stepwise fashion into adulthood, potentially due to trauma, although that's somewhat controversial. There may also be a low frequency conductive component as well, likely due to a third window effect. Moving on to infectious disorders, labyrinthitis is the first topic we'll discuss. So patients with labyrinthitis will present with sudden sensory neural loss and prolonged vertigo. There are two basic types of labyrinthitis. One is termed serous or toxic, and this is essentially degradation of the inner ear tissue fluid environment due to exposure to bacterial toxins, viruses, perilymphatic contamination with blood, inflammatory mediators or air. And it may very well have a similar etiology to certain presentations of sudden sensory neural hearing loss. Suppurative labyrinthitis is another phenomenon where there's actual bacterial invasion of the inner ear. This can be otogenic via the middle ear through a labyrinthine fistula, or it can be meningogenic via the cochlear aqueduct or IAC. And this is the most common etiology for deafness associated with meningitis. Important to note that acute otitis media and chronic otitis media are common, but sensory neural loss associated with these is pretty rare, and suggests that the oval window and round window membranes are pretty good barriers to pathogens and their toxins. No study has shown a clear relationship between sensory neural loss and acute otitis media. In terms of chronic otitis media, patients can have a mixed loss, although when studies have controlled for sensory neural hearing loss associated with surgery, there's no increased risk for sensory neural loss with chronic otitis media. Moving on to viral infections, a number of viruses can cause hearing loss. Herpes zoster, oticus, or Ramsay Hunt. This is a varicella reactivation with a herpetic skin eruption around the ear. Acute facial palsy is most commonly discussed in the clinical vignettes, but it can present with hearing loss and vertigo. Measles and mumps also have been shown to cause sensory neural hearing loss. Measles tends to be bilateral with moderate to profound loss. Mumps, on the other hand, is unilateral, can be reversible, and it occurs usually after the other mumps symptoms have begun, such as the flu symptoms or parotitis. Both are now relatively uncommon due to widespread vaccination. CMV, obviously a common cause for congenital and progressive loss in kids, but has been thought to be a cause for sudden loss in adults, although the evidence is somewhat lacking for this. HIV infection is associated with sensory neural loss. Mechanism is pretty unclear. It might be through direct viral effect, but opportunistic infection could also be a culprit, as well as drug toxicity, CNS neoplasms. It's important to consider HIV in patients with unexplained sensory neural loss and risk factors. Mosquito-borne viruses can also cause sensory neural loss, such as Zika, West Nile, and others. Moving on to bacterial infections that can cause sensory neural loss. Syphilis historically has been a major cause. Two ways that this can occur. One is through meningolabyrinthitis, which is seen in neurosyphilis. A little more commonly, you can see temporal bone osteitis leading to bone reabsorption, and then endolymphatic hydropsis is more commonly seen in late congenital, late or tertiary syphilis. Very difficult to distinguish this entity from Meniere's disease in terms of hearing loss, which is fluctuating with oral fullness and episodic vertigo. You may see a positive Hennebert sign, positive Tullio phenomenon, which have both been strongly associated with otosyphilis. Rocky Mountain spotted fever is a tick-borne infection caused by rickettsia. Patients can have the typical Rocky Mountain spotted fever presentation that is caused by a vasculitis that can lead to encephalitis, nephritis, and hepatitis, but it has also been associated with rapidly progressive sensory neural loss. Lyme disease, another tick-borne infection, with the best known ENT complication being facial paralysis, but it is also associated with sensory neural loss. Moving on to pharmacologic toxicity, aminoglycosides are probably the most well-known offender. These agents target hair cells by accumulating in the mitochondria, increasing reactive oxygen species, and then leading to cell death. There are agents that tend to be more cochleotoxic and others that tend to be more vestibulotoxic. These are important to know for boards. Cochleotoxic agents include kanamycin, tobramycin, amikacin, and neomycin. And vestibulotoxic agents are mainly streptomycin and gentamicin, although there is some crossover between these two. Antioxidants may be protective in when these agents are given. There are some studies pertaining to that. And then risk factors for increased ototoxicity include comorbid renal disease, longer duration, higher serum levels, advanced age, concomitant administration of other ototoxic agents, and certain gene mutations such as MTRNR1, which is a mitochondrial inherited genetic disorder. Moving on to ototopical agents. Topical aminoglycosides such as neomycin, gentamicin, tobramycin have long been used for otitis externa and otitis media, seemingly without a lot of side effects. This might be due to reduced permeability of an inflamed round window and oval window, which may be protective, but animal studies do show predictable cochlear and vestibular toxicity. And we also use, for example, gentamicin in a chemical labyrinthectomy for refractory Meniere's patients. So clearly there is potential for our ototoxicity. So in 2004, the Academy convened a consensus panel that recommended against the use of topical aminoglycosides in the middle ear unless an alternative was available. Also important to remember that older ototopic agents like acetic acid, polymyxin B, propylene glycol, etc., are also ototoxic. Moving on to other forms of pharmacologic ototoxicity, loop diuretics are often associated with reversible sensorineural hearing loss, although they may potentiate aminoglycoside-mediated sensorineural loss. Cisplatin and carboplatin, platinum-based chemotherapy agents, can also cause sensorineural hearing loss. We see this in about 25 to 86% of patients who are exposed. The loss tends to be worse in higher frequencies. You can see in this extended audiogram that, I'm sorry, this is not an extended audiogram. This just shows pre-chemo and post-chemo and long-term results of hearing results in patients who've been exposed to, I think this was a cisplatin study. This is likely mediated by reactive oxygen species generation. For board purposes, it's important to know that cisplatin, which has an I, is more likely to cause inner hair cell death as opposed to carboplatin, which has an O, is more likely to cause outer hair cell toxicity. Two other agents that can cause toxicity are antimalarials, such as quinine or hydroxychloroquine, and salicylates, which cause dose-dependent tinnitus and usually reversible sensorineural loss and vestibular suppression. Last items under the pharmacologic toxicity group include IV-vanc, erythromycin, PDE5 inhibitors, questionably Tylenol, ibuprofen, which have been shown in 2 large epidemiologic studies to potentially be related to sensorineural loss, narcotic abuse, and vinca alkaloids like vincristine and vinblastine. Moving on to renal disorders, we've already discussed Alport syndrome, briefly mentioned branchiotorenal. These are inherited syndromes that can affect both the inner ear and the kidneys. But acquired disorders are probably more important. Chronic renal failure, hemodialysis, and renal transplant have all been shown to be linked to sensorineural loss. This study on the right, the header from the study on the right, is from Paparella's group in Minneapolis, and it showed that about 15% of the patients in this group, who were patients who had undergone transplant or on hemodialysis, developed sensorineural loss. Difficult to determine exactly why, but a lot of these patients have electrolyte and metabolic derangements caused by the renal failure as well as the hemodialysis, and they often get a lot of loop diuretics and potentially are on aminoglycoside antibiotics and vancomycin. So the exposure to these agents and the altered pharmacodynamics caused by renal failure probably potentiates ototoxicity. Moving on to head trauma. Head injury can obviously cause loss in adults. This can be either directly through a fracture involving the otic capsule, or it can be through labyrinthine concussion, so a otic capsule sparing fracture, or even just a head injury without a fracture. And obviously penetrating injuries with stapes subluxation into the vestibule, which I'm sure a number of us have seen. Important note here, just from a clinical perspective, it's really important to get audiograms for patients who've had a temporal bone fracture, regardless of the fracture pattern. Even arguably for patients who've had severe head trauma would be good candidates for audiograms if there's any concern for potential hearing loss. Also under trauma is noise-induced hearing loss. This is a very common occupationally induced disability. It was first recognized in the 18th century. So interesting that it wasn't really a phenomenon or well-recognized phenomenon before the Industrial Revolution. Early in the 20th century, it was called Boilermaker's deafness, and it wasn't really well quantified until the development of the audiometer in the 1930s. And currently, noise exposure is regulated by OSHA, and this is a table showing noise level and exposure limits in terms of time. This does show up on boards occasionally. The best way to remember this is if you start with an 8-hour workday, you could be exposed to 90 dBs for that entire duration. And then every 5 dB increase in noise level, you cut your exposure limit in half. So by 95 dB, you can only get 4 hours, 100, 2 hours, 105, 1 hour, etc. That's potentially helpful thing to remember for boards. Under noise-induced hearing loss, again, noise is essentially unwanted sound. It's characterized in terms of its intensity, its time course, so there's continuous, fluctuating, intermittent, whether it's an impact noise, which would be two objects colliding together, like in a steel factory, or an impulse noise, like an explosion, for example, in mining or military service. Spectral content is also important for the type of hearing loss that patients are at risk for. Pure tone, narrowband or broadband should be considered when characterizing noise exposure. What happens with patients who are exposed to unsafe noise levels is they develop a temporary threshold shift, so temporary hearing loss. They can recover, but after repeated exposure, they develop a permanent threshold shift and permanent loss. Acoustic trauma is essentially noise-induced hearing loss, but it's a single noise exposure resulting in a permanent threshold shift without a temporary shift. Noise-induced hearing loss tends to be symmetric and bilateral, with the greatest loss from 3 to 6 kilohertz. Most loss occurs during the first 10 to 15 years of exposure and then progresses slowly after that. These two figures are from the Cummings chapter. The figure on the left shows the 50th and 95th percent confidence limits for 20 and 40-year noise exposures to 90 decibel sound. And the figure on the left, and the figure on the right shows speech frequency average noise-induced threshold shifts as a function of duration and level of exposure. So clearly, the more time, more decibel exposure, greater loss. The role of the otolaryngologist in managing these patients is essentially identification and prevention. There's really nothing we can do to reverse this loss. Also under trauma is perilymphatic fistula, which is a controversial topic. This can occur with severe barotrauma, with flying, diving, or slap injury. It can also recur as a result of temporal bone trauma. It has been described as being caused by heavy lifting or straining, or as a complication of middle ear surgery. Labyrinthine fistula can also occur from cholesteatoma. Certain congenital disorders like Montini dysplasia or X-linked stapes gusher can potentiate this. There's some question as to whether it can occur spontaneously. History and physical. Typically, these patients will present with sudden loss and vertigo following an audible pop. There may be a positive Henneberg sign, positional nystagmus with the ear in the dependent position. In terms of diagnosis and treatment, this is very controversial, but what can be offered is middle ear exploration with packing of the area that's in question with any tissue. But there's really no definitive diagnostic test for PLF. There's really no clear consensus on diagnosis and management. Important to note that just seeing fluid near the oval window or round window on a middle ear exploration is not definitive. This could be fluid from mucosa or a collection of local anesthetic or irrigation. Moving on to radiation. Radiation therapy can cause sensorineural hearing loss and has been shown to do so in about 50% of patients. The effect is dose dependent. likely mediated by reactive oxygen species with damage to the inner and outer hair cells. Loss usually occurs about 6 months to 2 years, and then is progressive after that. For fractionated radiation therapy, the cochlea seems to be resistant at doses less than 45 gray. Fortunately, this it may be hard to avoid for a lot of the patients getting head and neck cancer. In terms of stereotactic radiosurgery, there can be damage to the inner and outer hair cells, the stria, spiral ganglion cells. Time course for hearing loss following SRS is poorly characterized, but hearing has been shown to be worse at 1 year with doses as low as 4 gray. And fewer than 25% of patients maintain serviceable hearing in about 10 years. So it's important to counsel patients in the long term, maybe not in the short term, but in the long term, the risk of sensorineural hearing loss is about as high as with microsurgery in management of vestibular schwannoma. Moving on to neurologic disorders, multiple sclerosis is a relapsing remitting multifocal CNS demyelination disorder, leaving inflammatory changes and scarring throughout the CNS. Women are more affected, Caucasians are more affected, young people are more affected. About 4 to 10% of patients can develop sensorineural loss. The timing is very variable in terms of, or the presentation is very variable in terms of timing and symmetry. There may be some recovery. Speech discrimination can be preserved or can be very, very poor depending on the site of the lesion. And ABR can be abnormal, showing increased wave latency, and important to know that this can be one of the diagnostic criterion for MS in addition to MRI. Idiopathic intracranial hypertension is increased ICP without an obvious cause. Risk factors include obesity, female sex, childbearing age. Presentation can be very variable: headache, transient vision loss, pulsatile tinnitus, and vertigo. Sensorineural loss can be seen in these patients, and it's thought to be potentially from transmitted perilymphatic pressure or potentially from cranial nerve 8 stretch or compression injury. Supportive findings include papilledema on exam, a high LP opening pressure, and management is typically through weight loss, acetazolamide, and potentially an LP shunt. Moving on to vascular and hematologic disorders, basilar migraine is a relatively rare migraine variant that can present with vertigo, tinnitus, oral fullness, distortion, and recruitment. About half of patients who meet criteria for this have some low frequency loss. Not to be confused with vestibular migraine, in which patients, a little over a third of patients with vestibular migraine will report a subjective loss that's not as well characterized as to whether this is really a sensorineural loss though. Vertebrobasilar artery occlusion is another vascular cause for sensorineural loss. This is typically due to ICA occlusion. ICA supplies the labyrinth via the internal auditory artery, so you can have a peripheral lesion of the labyrinth. It can also result in ischemia to the brainstem and the cochlear nuclei. Other symptoms that would go along with an ICA occlusion include vertigo, facial palsy, ipsilateral gaze, paresis, loss of pain, temperature, and sensation of the face, and Horner syndrome, and then a contralateral loss of pain, temperature of the trunk and extremities. Some other vascular and hematologic disorders worth mentioning: immune complex mediated hyperviscosity and cryoglobulinemia, sickle cell disease, which can cause, which is associated with hearing loss in about 22% of patients, leukemia, lymphoma, cardiopulmonary bypass, and potentially vascular loops in the CPA or IAC. Moving on to autoimmune disorders. First, discussing systemic disorders. Cogan syndrome is probably the most tested phenomena. This presents with interstitial keratitis and auditory vestibular dysfunction. Tends to be responsive to steroids and immunosuppression. Important to remember that these patients can have ossification of the cochlea due to inflammation. So if profound loss is present and there's no recovery, it's worth discussing early cochlear implantation with them. Also important to know that this can be associated with medium and large vesicle vasculitis with aortic involvement in about 10%. So these patients should be referred on for additional workup. Other systemic disorders, autoimmune disorders that can lead to sensorineural loss include polyarteritis nodosa, relapsing polychondritis, and GPA. There's also a phenomenon known as primary autoimmune inner ear disease. This is typically seen as a bilateral sensorineural loss that's responsive to immunosuppressive drugs, and it is often associated with vestibular symptoms. Moving on to bone disorders, First, otosclerosis, which is really better characterized as otospongiosis. This involves rest of metabolically active otocapsule bone that, as they turn over, can not only fix the ossicles and the stapes footplate, but can affect the cochlea, leading to progressive sensorineural loss late in its course. This disease process can stabilize with bisphosphonate treatment, more controversially, potentially with fluoride treatment. And important to remember that in very far advanced otosclerosis, which is otosclerosis presenting with a quote unquote blank audiogram, meaning non-measurable air and bone thresholds, these patients actually may have serviceable hearing that's not detectable by the audiometer. The audiogram in the middle on the right shows a preoperative testing for a patient with very far advanced oto. And this patient underwent a stapes surgery, and you can see that their ADA thresholds are actually quite decent. So a quote unquote blank audiogram may not be the final story for these patients. So it's worth considering a stapes surgery prior to proceeding with a CI for them. The CT on the right just shows the classic halo sign, for patients with cochlear otosclerosis. Paget's disease is another bone disorder that can lead to hearing loss. It tends to affect older people more than younger people. About 20% of patients in their 80s will have this. 50% will have some hearing loss. It can stabilize, however, with calcitonin or etidronate sodium treatment. Moving on to neoplasms. This should be on the differential for any unilateral or asymmetric loss, especially when the presentation isn't typical for Meniere's. And these lesions will typically originate in the IAC, the CPA. Vestibular schwannoma is the most common cause, or common tumor causing sensorineural loss. It comprises about 6% of intracranial tumors, but 80% of CPA tumors. These patients will usually, not always, but usually have progressive unilateral high frequency sensorineural loss. The loss, however, can be sudden in as many as 10% of patients, and it can have really any audiometric pattern. Speech discrimination is often reduced out of proportion to pure tone average, which is a phenomenon called rollover. And patients may have very variable vestibular symptoms. Often they have none, but they can have severe symptoms. And recall that bilateral vestibular schwannoma is pathognomonic for NF2. The other main neoplasm in the CPA causing hearing loss has been angioma. So 15% of CPA tumors, very similar presentation to schwannoma, but less effect on hearing per unit size for unclear reasons. The remaining 5% of CPA lesions includes dermoid cysts, lipomas, arachnoid cysts, glycerol granulomas, and angiomas. Other skull-based lesions should be considered as well, including metastatic lesions, perigangliomas, sarcomas, hemangiomas, adenomas, lymphomas, and leukemias. Other causes not well categorized include endocrine or metabolic disorders. Both type 1 and type 2 diabetes have been epidemiologically linked to sensorineural loss. Congenital hypothyroidism has been linked as well. There's no convincing evidence for adult onset hypothyroidism, hyperlipidemia, or parathyroid disorders. Also worth considering non-organic causes, including factitious order or malingering for primary or secondary gain, or conversion disorder, which is non-intentional. Any discordance between pure tone average and SRT is a strong indicator that this may be happening, and you can clarify the situation with an ABR, an OAE, or a Stanger test. Moving on to disorders of unknown etiology, age-related hearing loss, formerly called presbycusis, is very common. Strictly speaking, only sensorineural loss attributed to aging, not to genetics, environment, vascular, metabolic factors should be called presbycusis, but it's not really possible for us to study this very well. So we more appropriately call this age-related hearing loss now. And it is a very common phenomenon that affects about 2/3 of individuals over 70. It's a major risk factor for cognitive and physical decline. And it tends to be worse in higher frequencies and is more severe in men. And these two figures here show median pure tone thresholds for a group that's highly screened to exclude noise exposure. So for age-related loss, there are some proposed types per Schucknecht based on histologic studies. These include sensory type, which is loss of hair cells, neural, which is spired ganglion and auditory nerve fiber deterioration, strial or metabolic, which is atrophy of the stria vascularis, and mechanical, which is questionably due to increased stiffness of the basilar membrane. Most patients will show a mixed pattern, but 25% on histopath studies have shown none of these studies. There's none of these findings. Other disorders of unknown etiology, Meniere's disease, and then lymphatic eye drops. Again, this is episodic fluctuating sensorineural loss, tinnitus, vertigo, and oral fullness. Loss is typically low frequency sensorineural initially, and then progresses to permanent loss across all frequencies. The hallmark of this disease is variability and unpredictability in terms of extent of progression, severity. Treatment options include sodium restriction, diuretics, systemic or IT steroids, endolymphatic sac decompression, shunting, or labyrinthectomy in refractory cases. Moving on to sudden sensorineural hearing loss before we move on to talk about the article. So the definition for sudden sensorineural hearing loss in our guidelines is derived from the National Institute on Deafness and Communication Disorders, and it's defined as a at least 30 dB decrease in 3 contiguous frequencies within 72 hours. But it's important to note that this is a starting point for our guidelines, which recognize the limitations of this definition and allow for expanding treatment to more mild losses in actual clinical practice. Incidence for sudden loss is about 5 to 20 per 100,000 persons per year, tends to peak in the 6th decade. Additional symptoms include oral fullness, tinnitus, vertigo, and disequilibrium in as many as 40% of patients. There are some important prognostic variables, including severity of loss. More severe is worse. The shape of the audiogram. An upsloping or mid-frequency loss is better. The presence of vertigo also portends a worse prognosis, as does greater age. About 30 to 65% of patients will improve without treatment of any kind, and this usually occurs within 2 weeks. The principal proposed etiologies for sudden loss include viral neuritis or cocleitis, as about a quarter of patients will report a preceding URI, and there are some studies showing increased viral titers and otopathology consistent with viral infection. Vascular occlusion is also an attractive hypothesis given the tenuous blood supply to the labyrinth, but anatomic and histologic studies haven't found any clear evidence for this. Intracochlear membrane breaks are also a proposed etiology, although this is controversial. And then autoimmune disorders as well, which is supported by the fact that some of these patients seem to be steroid responsive. But important to recall that this does not rule out retrocochlear pathology, as some patients with a CPA lesion and sudden loss may be steroid responsive. There are over 100 proposed etiologies for sudden sensorineural loss. I won't be getting into all of them, but essentially this is a recapitulation of all of the topics we've already discussed, with the caveat that the loss is sudden and maybe not as well identified or tied to these causes. Sudden loss is often treated with systemic steroids. The evidence for this is conflicting. One randomized study by Wilson et al. Showed that patients with a mid-frequency loss recovered completely regardless of treatment, while those with a severe loss of more than 90 dBs at all frequencies had no recovery, regardless of what treatment group they were in. Systematic reviews and meta-analyses have concluded that steroid effectiveness is ultimately unproven, but we still often will initiate therapy just given the risk-benefit ratio. We typically start at about 1 mg per kg per day, up to 60 milligrams with a slow taper. This can be extended depending on how patients respond to therapy. Intractapanic steroids are often used as well. They are equivalent to, or not necessarily, or at least not superior to, systemic steroids. Meta-analyses have shown some significant treatment effects when used for salvage treatment in patients with incomplete or absent response to initial therapy. Other potential options for treating sudden loss include hyperbaric oxygen, which does have some evidence supporting it, vasodilators, ibuhistamine, oral heparin, carbogen, dextroammannitol, heparin, some iodinated contrast agents, as well as antivirals. Lastly, the key action statements from the most recent guidelines for sudden loss are included here and on the next page, which I'll just advance too quickly. I'm not going to cover these in detail now for purposes of time. If you care to review these, you can download the lecture, pause it, and read them. But just understand that these guidelines are available to us. They've been recently updated, and they will likely be an important point of departure for talking about Alex's article. So thanks very much. If you have questions, please feel free to email me. I will see you when I get back from vacation. Thanks, everybody. Bye-bye.